Hello there, my name is Dee Campbell and welcome to my presentation on how to set up a compliant patient home visit program or telehealth visits. Many of us in health centers are experiencing issues with our patients not being able to come in due to ICE's heavy presence and some of them being in hiding. So all of us are trying to get creative and try to find a way to make this happen. Honestly, I've been looking at this for a few days now and playing 5D chess with it, and really I got nervous for a while there. However, once when I changed my perspective from more or less looking at this as a 1950s house call back in the old days when doctors did just visit patients all the time, honestly, I started getting a lot more optimistic about it. So let's kind of crack this egg and try to find the best way that we can deliver our patients' care in this trying times. So I broke this down into 3 separate scenarios that we will be dissecting this into. The first one is simply taking advantage of telehealth while we can. We're all still used to telehealth guidelines, but we will break it down a little bit here. Telehealth does use E&M codes still, despite the new codes being created back in 2024, but none of those codes actually got recognized because we're all used to this E&M system, so why break it? It works fine. So how these work is you use your E&M codes, normal level like you do, your coding and billing, attach specific place of service codes to it based off of the location of where the patient is, and that helps make sure we get payment. And then there's also modifiers that you must attach, modifier 93 if it's audio only, modifier 95 if it's audio and video. That would be one way of doing it. The second way of doing it is what if you need to get vitals, but a provider doesn't need to necessarily be there. We call this the RN visit in Provider Telehealth. This will actually still follow the same telehealth guidelines that we will have here, just the only difference is we have an RN there. But ultimately the E&M code is based off of the provider and what the provider is doing, so thus all of that's going to actually act the same. And then the third way that we're going to look at this is provider actually visiting the home. Maybe something happens that makes this the provider has to visit them. Maybe you have a midwife team and you need to do ultrasounds or stuff like that. The major differences between these is we will use their own separate codes here. They do have their own code set for it. We will not use the E&M office visit codes. That's why we won't be using those. Instead, we'll be using the E&M home and domiciliary codes. Place of service code does change though to 12 instead of 10 for at home, so just be aware of that. And also for your billers, be aware that it uses a different revenue code for a home visit. I assume most systems is going to be set for a basic one or your default, so just make certain you have something on the back end for this. Telehealth has a federal law. Truly, there's not a lot in there for the documentation guidelines. It's very basic and more just discuss how telehealth works in general. What you will see in the federal laws is it does state that you have to document how the service was done, i.e. whether or not it was audio only, video, if you use Zoom or HEMA. It does also have the distance site and originating sites that you have to document, i.e. where you are as the provider and where the patient is. They have recently made it so as a provider, if you are at your home providing telehealth, you can use your clinic's address due to concerns of doxing. They did finally make that a thing. So don't use your personal address. You don't have to. By no reason should you even do that. And finally, they do expect you to document the reason why you think telehealth was appropriate. What I wanted to break down though is Minnesota guidelines. I would recommend if you're viewing this from a different state, please review your guidelines as well. Minnesota has its own specific laws for telehealth where we break down what we want and expect to be documented at every visit. If you can't find your own state's documentation guidelines and all you're stuck with is the crummy federal guidelines, I would honestly recommend using Minnesota's. It's very robust. I really don't think you're going to miss any information, and this is what we expect to be documented in Minnesota. 1, the type of service being delivered through telehealth, kind of same thing. What kind of service are you doing? The time that the service began and started. They also say please use AM and PM designations for when it started. The healthcare providers determining that telehealth is appropriate and effective means, just a little statement about why you thought this was an effective way of delivering care. The mode of transmission that was used, this will be what kind of platform you use, whether or not it was audio and video or video only and so forth. Once again, we have the location of the originating site and distance site, same thing as the federal guidelines. And finally, all of this is just stating that you must do all of this to receive payment. So just be mindful of the telehealth documentation guidelines that you have in your individual states. This is what we have here in Minnesota. If you can't find your specific state guidelines, I would highly recommend maybe adopting ours. Where you can find your state-specific laws is I highly recommend the website CCHP. I have it linked in the sources. Really good for finding your state laws. Concerns about telehealth in general is what I already mentioned was the state laws. Just make certain to check with your state laws and what you have in your state. Minnesota here, we are quite a bit more telehealth positive, so that's some good news that we have going on. I'm not certain how each of your individual states work, so please be mindful of that. Right now, we are currently set for Medicare will end all coverage for non-behavioral health services effective end of this month, January. However, there are some good news going on with there. One being the DEA and the HHS have actually both agreed to extend the substance abuse prescribing via telehealth until the end of 2026. I would say this is a really promising sign of they're probably going to extend it again. One of the major issues going on right now is since COVID, we've gone through, I think it's 6 different extensions at this point. The federal government really hasn't made a permanent law for telehealth yet, so now we're kind of stuck more looking at what our states are going to do. So currently it is set that Medicare will expire at the end of this month, but all signs read to they'll probably extend it again, but hopefully we will have permanent legal policy at some point. So for my state here, I have a few laws here to mention about it. Minnesota has recently removed the basis of geographic and location. This is phenomenal news. One of the biggest fears for telehealth pre-COVID is it used to be you could only do telehealth if you were in a shortage location. Depending on your state, it still may be that law. But at least here in Minnesota, whether or not you're in the metro or not, no longer matters. You can perform it, and MHCP will cover telehealth services. So that's a good news. Bad news is Medicare may or may not be covering it. However, I think we're all used to not getting paid for all the services that we do. It's just how it is being a clinic. For example, I have this Minnesota law here that states for telehealth visits, we will not get paid for audio-only visit or encounter rate. So whenever we have a telehealth visit that patient can't connect a video, we just accept the fact that we're not going to get paid our PPS rate. It is what it is, how life is as a clinic, so sometimes we gotta accept certain things. Medicare just may go away at the end of this month here, and we'll just have to all keep our eyes on it. So with looking into that, which payer guidelines should we follow? That's kind of a serious question when it comes to that. For FQHCs, we have this policy here that states all of our charges and the way we treat patients must be the same regardless of their insurance status. So quite simply, how I recommend approaching this is pick one and commit to it, regardless of the patient. Regardless of the patient's status. So choose one as your policy as a clinic and just stick with it. I would just recommend it based off of what's most common for your clinic. Is Medicaid the most common payer in your clinic? I would probably follow Medicaid guidelines then for every single patient. Is Medicare your most common payer? I would probably follow Medicare's guidelines then for every single patient. If commercial is your most common payer, which I highly doubt if you're an FQHC, maybe if you're an RHC, I would then recommend pooling at least the top 5 biggest payers of your commercial payers, review their policies, and then base your clinic policies off of that. But remember, as FQHC, we must treat everyone the same, always consistent, always uniform, regardless of what insurance they have. So for that reason, pick one. Personally, for Minnesota, I would recommend picking the Medicaid guidelines because MHCP has declared that they are willing to pay for it. So let's go with them. Now on to the home visits, the fun part. Home visits are going to be built a little bit differently. We're going to use codes here that honestly I'm not even used to using that often, so it's kind of fun for me to look into. There is this whole coding group for 9934441. You will see here this note that effective January 1st, they ended up merging two family of codes. So that's why we have the language of domiciliary, rest home, and boarding home, and the patient's home all included. All have been grouped together into one single family of codes. That's why you'll see them listed under the place of services as well. But obviously, as we're all aware of how we're setting up this program, we will be living in place of service 12 for these visits. So let's look into what it's going to look like doing these. When we started looking into doing this program ourselves, one of the big questions I came up with is what kind of supplies are we going to need? One of the big policies for home care visits is the care provided must be essentially the same as what they could have gotten at an office visit. I'm just a coder and I review documentation and I love CDI and law. For that reason, I don't fully know everything that you guys will need, but I know that this is useful information. Luckily, the AAFP has this list here, actually, of all the items that they would recommend you bring with yourself to those home visits. I just recommend printing this out, reviewing it, kind of checking off which ones you think are pertinent for your clinic. Documentation for home visits. The next two slides are going to be somewhat of repeats. I found two different major resources from CMS and Medicare, and another resource that had slightly different guidelines for them, but I wanted to combine it all together so that way we make certain we're following everything properly. So we'll just break this down in order. What they expect for documentation for medical necessity. The mere presence of an inactive or chronic condition does not constitute medical necessity for any settings, which is what you would expect. You just have to justify it. So what we need to document is chief complaint or specific reason or reasonable and medical necessity is required for each visit. Normal. A payable diagnosis alone does not support medical necessity of any service. Medical necessity must exist for each individual visit, so just make certain you document each time why this visit is okay for doing it and why it was medically necessary. Visits will be regarded as social visits unless the medical record clearly documents the medical necessity for every visit. So just make certain you're very much documenting the medical necessity for your visit. Always like it's saying, it will be treated as a social visit, and that means you're probably not going to get paid for it. Services/visits must be medically reasonable and necessary and not for the physician's or qualified MP's convenience. As we can all understand, this isn't really for our convenience at all. Quite frankly, it's the opposite. So check, we're not doing that. Service must be equal quality to a similar service provided in the office. So like I mentioned before, that's why I shared the supply guidelines, since they should be essentially the same. Frequency of visits required to address any given clinical problem should be dictated by medical necessity rather than the site of service. So just make certain you clearly show it. It is expected that the frequency of visit for any medical problem addressed in a home setting will not exceed that of an office setting, except on rare occasions. So just follow the same policies. If you're dealing with a pregnant patient and you're going to be seeing them at their home, just make certain you're following the normal protocol guidelines like you would in an office. Just don't exceed it. Don't go above and beyond. Training of domiciliary staff is not considered medical necessary. And finally, let's go over to documentation that supports the home visit. A home visit must be reasonable and necessary and not just for convenience. This is one little concern of right now, so just make certain you document why the patient had to be visited at home, that maybe it's worries, something like that, for ICE has them scared, or just make certain it's clear that it wasn't for their convenience, but you had to see the patient at home. It was for the best of the patient that you saw them in their house. Just make certain that's clear. I think given the circumstances, it's pretty easy to justify how necessary it is. Physicians also cannot provide home services at their convenience. We already tackled that one. It doesn't really seem like it's for their convenience at all. As with any E&M service, documentation must include the chief complaint, so blah, 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 document the normal stuff that you would. And service provided by a physician or mid-level practitioner cannot be services that could be provided by a visiting nurse or a home health agency under Medicare home benefits. E.g. just a basic blood pressure check, dressing change, that kind of stuff. So more or less it's saying if it's a service so basic that just a regular nurse visit could have done it, then probably don't bill for it. But if you have to do it, still do it, but understand that you're probably not going to get paid for it. On this slide, we'll be breaking down more information on the home and domiciliary visits. I apologize if I'm saying that word wrong every time, but hey, I'm just having fun trying to say it. First guideline that it says is it states about duplicate care. What this guideline is stating is just make certain you confirm with your patient that you're doing house visits, that no other clinic is also doing house visits with them, or if they're getting house visits through any other means. What this is stating is if more than one happens same day, it's more or less going to be whoever sends out the ticket first is going to be the one who gets paid. Both visits won't get paid. Second guideline is pretty standard, just stating that laboratory and diagnosis tests must be medically necessary, same thing that we have in a normal office. It's guideline 3 that's a little weird when it comes to labs. I'll read it out for you. If the results of testing will not change the medication management or results in surgery, there is no medical necessity for the procedures. In these cases, the testing would not be medically necessary. So just be aware of that. Labs, that's just saying if it's not going to affect the patient's actual care, they're not going to pay for a lab draw at a home visit. Diagnostics tests performed during a home visit must be ordered or personally performed by the physician or qualified NPP who is the provider of the record and be responsible for managing the entire disease process addressed in that visit. So just saying, don't do another provider's orders at a home visit. Only do your own orders. If you're the one there, it doesn't really matter if one of your coworkers ordered something 2 weeks ago. I would recommend you only do your individual labs. And then this one has its own diagnoses that support medical necessity. Same statement, more or less, the mere presence of an inactive or chronic condition does not constitute medical necessities for any settings. There must be a chief complaint or a specific, reasonable, and medical necessary need for each visit. In support of this, the documentation of each beneficiary encounter must include the reason for the encounter and relevant history, physical examinations and prior diagnostics tests and results, assessments, clinical impressions or diagnoses, in medical plan of care, including how the visit will change the care of the beneficiary. So really just standard stuff. Just make certain you would document the visit, why you did it, why it had to be done at home, and after that, just do everything else you normally would have done. The home visit codes, much like a regular office visit code, can be billed on time or it can be billed based off of medical decision making. I just want to note though that as the AMA guidelines say, do not bill for your travel time to the patient. Travel time cannot be included in the visit. All what is included in the time is all of this here. So the stuff that you do at the actual visit itself, or like the pre-work of researching all their information, that kind of stuff. But do not count your travel time. If it takes you 20 minutes each way to get to the patient, sadly it doesn't matter. Homebound rules. This was the part that had me nervous and really had me having to look at this. And I found a lot of conflicting information once when it came to the homebound rules. What got me concerned is when you look at CMS Chapter 13 or any CMS direct information on home visits, it does have this homebound status still indicated on it. So I started digging more and more about it, and I kind of got more confused than anything. One, I found in the AAFP, it indicated that as of January 2019, they removed the medical necessity being required for every single visit. I thought, that's kind of interesting. And then I looked at Nordian's website. This would be jurisdiction E. They're the ones who manage it, would be California, Hawaii, and Arizona, I believe. Sadly, NGS is who I have in Minnesota, and their website is garbage. It's terrible to search. All I could find for home information was just due to cognitive patients. But on Nordian's Medicare website, it also says there's no requirement for being homebound. So I looked more into this and I found CMS has this guideline that they released in 2019 that also states that the medical necessity has been removed from it too. So it does seem that the homebound status is actually not really the case, and nor does it matter anymore. And as another conflict, in CMS's book, chapter 13 for RHC and FQHCs, it actually lays out that you can bill for a homebound patient visit if they only see an RN or an LPN. So looking at 4 different sources indicating to me that homebound status is actually null and void and no longer matters, I'm going to say it no longer matters. So I would just say go see patients who need to be seen. We're looking at this as old-fashioned house calls. It is an old-fashioned house call, and that's what we're doing. We're doing things just like how it used to be done. FQHCs and RHCs from this point on is going to be FQHC information only. In guidelines 40.1 for locations, it does state that patient's residency is a billable location. So yay, yay, yay for us. Looks like we are good there. And then looking at the FQHC qualifying visit list, the home visits are actually on it. So that is actually very cool. So that means we will get paid our PPS rate for home health visits. Note this list hasn't been updated since 12/6/2017. So that's why these codes are still here, even though they are all dead at this point and combined. So just keep that in mind. All of these have gone into these codes now, but we still have them, and that's all that matters. We will get paid our PPS rates for using these codes. Finally, here are all my sources for this information. I appreciate everyone getting creative and trying to find ways to help out our patients. I hope that this information helps make you all confident too, that actually it looks like we can do home health visits in Minnesota with really not much of an issue. At our clinic, we're going to start doing this here soon. Biggest change we had to do is just update our HRSA scope, so we're doing home visits. That was pretty much about it. So yeah, I highly recommend you guys start seeing your patients who are in hiding. There's really no need to be afraid of it. It looks like we can do it too. So have fun, get out there, and treat your patients. Thanks for joining me. Bye.